Good morning. Thank you for coming. My name is Sarah Tilstra. I'm a clinician educator at Montefiore. I'm one of the presenters today. Roseanne couldn't be here to introduce us. This is Dr. Debbie DiNardo. She's one of the clinician educators at the VA and did most of her residency training here. And she's currently getting her master's in medical education. And I think that you all know Dr. Bill Follansbee, which is really the reason why we're here. I told him he has too many titles to introduce him appropriately, but know that he is a master clinician and a professor of cardiovascular medicine. So today we're going to talk about combating cognitive bias, a diagnostic checklist for internal medicine residency training. So let's start with that outline. My microphone's on. We're going to first talk about diagnostic error and go through the theory behind clinical reasoning, how we all make decisions. Then we're going to lead into cognitive bias. We're going to talk about debiasing strategies, so things that we try to do to kind of combat that bias. We're going to talk about checklists and their use in clinical reasoning. And then lastly, we're going to talk about our project that we've been doing over the last couple of years. So let's start with a case. So this is a 63-year-old man. He has a history of localized squamous cell carcinoma of the left lung, status post resection, and XRT. He's known to be cancer-free. He has chronic hepatitis C, COPD, CAD, and schizophrenia, who presented to the VA with recurrent fatigue, nausea, vomiting, and diarrhea. This is his 4th hospital stay for the same symptoms. During his previous admissions, he was presumed to have a viral gastroenteritis. Seems reasonable. But each time he experienced significant improvement with the symptoms just with IV hydration alone. The team sent him home in a couple days to follow up with his PCP. Good thing Dr. DiNardo was taking care of him the 4th time around, because he was eventually diagnosed with adrenal insufficiency, which if you think about him from the 1st time or even the 2nd time, maybe that probably makes sense. But this was on his 4th hospital stay. And so as we go through this talk, I want you guys to think about a few things. Why did it take 4 hospital admissions to diagnose this patient? Would you consider this a diagnostic error? And if you do, who do you report it to? And is it reportable to anybody? Was the team biased in any way? And whose responsibility is it to curb these diagnostic errors? Lastly, are physicians teachable? We like to think that we are. And are there any tools to facilitate more effective clinical decision making? So how good are we at diagnosis? I usually put Dr. Painter on the spot, but I won't put anybody on the spot right now. Have you ever thought about your own rate of diagnostic error? Like, have you ever sat back and say, wow, I've messed up about 5% of the cases I've ever seen? It's something probably we don't like to think about, but it's true. We all mess things up. Diagnostic error remains a serious but very underestimated patient safety concern. And the precise estimates of prevalence are difficult to measure, but the data say it's probably somewhere between 10 to 15%. Estimates of 40 to 80,000 hospital deaths occur each year because we diagnose them incorrectly. We don't report it. Again, who do we report it to? And we're rarely even aware of it. We all see cases from outside hospital that come in and they were poorly managed and we think we're awesome because we fixed them. But how often does that happen to us too? So from a Harvard Medical Practice study, of the adverse events due to physician error, misdiagnosis was more common. The medication errors, and we usually focus on medication errors, was more likely to be judged as negligent and to result in disability. So we harm people more and we're more negligent. And of the patients who die in an ICU, the prevalence of misdiagnosis is estimated to be about 28%, with a class 1 error, meaning very bad, can lead to death, of about 8%. So those numbers are a little sobering. One more for you. The study of the U.S. National Practitioner Data Bank, over 25 years, they looked at about 350,000 claims. And diagnostic error was the leading cause of claims, had the highest proportion of total payments, and cost us $39 billion. So how do we reduce it? So you would think that knowledge deficits are really the heart of diagnostic error. But if you look at all the data, it's actually typically not the cause, and the cause is more of the faulty synthesis of information. So we process it incorrectly. And so a major component to the solution has to come from a reduction in the decision-making process, and that's why we're here today. You know, Greg Bundt does a lot of system-based improvement in terms of medical errors. And the most recent IOM report that launched this whole movement actually never commented on diagnostic errors. But upon petition from the Society to Reduce Diagnostic Error in Medicine, the IOM is now committed to putting out a report later this year, which I think, again, will also be very sobering for all of us. So clinical decision making. So it's very complex. It's multifactorial, especially in the world of doctors. We're tired. We're hungry. We get bugged all the time. We get paged. And the theory behind our clinical reasoning is dual processing. So there's two types of systems. One is intuitive, also known as System 1 and Type 1, and one is analytical. And I'm going to go into both of these. So intuitive reasoning, it's fast, it's automatic. It doesn't take that much cognitive effort, and it's hardwired. It relies on pattern recognition and experience. So think of dermatologists that go into the room and see 70 patients a day. They spend 30 seconds in the room, and they know what the disease is. It's kind of like using your rules of thumb. No reasoning occurs here. It's mostly reaction to pattern recognition. And it's usually accurate, but it can be error-prone. There's a lot of bias that leads to these intuitive reasoning errors. And per Wikipedia, about 100 have been cataloged over the years. And it's kind of like driving a car on a sunny day. There's no reason why anyone should get in an accident if they are appropriately driving a car on a sunny day with no traffic. But we all know that accidents do happen. In terms of the cognitive biases, I want to highlight a few. In some of the research in clinical reasoning, they found that many of the biases, there's about top 5, and so I'll go through them. So the availability heuristic. So it's a likelihood judged by the ease of recall. So I have a certain pattern recognition in my head. I've seen 100 PEs, and a guy comes in with chest pain, shortness of breath, pleuritic. I think he's got a PE. I know that pattern. It's available to me. But if I see somebody that I've never diagnosed before, some zebra, it's going to be harder for me to pick up on that because I've never seen it before. You're also more likely to diagnose things commonly of things that you have seen. Anchoring bias is really retaining the initial impression of disease even when the disease process is changing and new information is coming toward you. Okay? It's failing to kind of incorporate that new information into the new diagnosis. Premature closure is just that. We think we have the diagnosis and we stop there. We don't go seeking information to kind of refute our diagnosis when we think that we already have it. The framing effect happens probably in every patient because there's a lot of handoffs. So if I get a patient from the ER that's labeled to me as NSTEMI, they come up to the floor, my thought process is already thinking that he has an NSTEMI. It's labeled to me that way, and I stop my forward thinking. And the last that I actually have seen my team do a lot this month is affective bias. So we have a certain subset of patients that really get to our emotions. You know, they're hard to deal with, they're in the hospital all the time, they complain, they hammer page my house staff, and they let their emotions get in the way of their objective cognitive thinking. Like I said, there's about 100 cognitive biases, but those are the ones I wanted to go over. This is Dr. Follansbee's favorite quote. Misdiagnosis is like bad breath. You really only see it in others. It's hard to pick up, okay? Nobody's tapping you on the shoulder saying, hey, maybe you should think harder about this case. So why should we care? Bias is unconscious. There's no objective way to assess for it. And it affects our clinical decision making. So let's move on to this analytical type 2 system 2 reasoning. It's slow, it's demanding, it's deliberate, it takes time. It's taxing. It's inherently more accurate than your intuitive processes, and it's particularly valuable in complex cases. Whenever we have no idea what's going on, all of us do this. We all think harder about the case, pull out all the pieces, and we think deliberately about it rather than relying on our pattern recognition. It's like driving a car in good weather, but then you hit a hailstorm. You turn down the radio, you put on the windshield wipers, you slow down, you switch from your intuitive to your analytical processes, and it's very deliberate. So why do we make mistakes? So Graeber, this is kind of one of the landmark papers from 2005. He analyzed 100 cases of diagnostic errors. And they fell into 3 buckets. So there was a no-fault bucket, which is patients didn't follow up with the testing they were supposed to do, or it was a really weird presentation of disease that nobody would have gotten anyway. There are system-related errors, so misreporting a lab test, organizational issues, the equipment didn't work. And then there's cognitive errors. And when you look at the percentages, no fault was 7%, system errors were 65%, and the cognitive errors were clearly the highest. So in 74 cases out of those 100, we could attribute the error to a cognitive mistake. And the shocking thing was that a knowledge deficit was only present in 4% of them. So we had all of the knowledge to figure out the case. We just synthesized it inappropriately. Thus, the knowledge gap is not necessarily implicated in errors, but rather a defect in the processing. So are we trainable? Reflective reasoning. So what reflective reasoning is, it's more of a literature term. A lot of the studies in clinical reasoning have been using this technique. It's a strategy to force participants to think deliberately. So you have a case, and you're made to go through a series of questions. And if you answer the questions, we can kind of say that we made you reflectively think about the case. And the typical format kind of goes like this. You list the hypotheses, you find things that support and refute the diagnosis, you list alternatives, and then you kind of come up with your final set of diagnoses. We made you sit down and write this out and think about it. So can it be used as a cognitive debiasing strategy? And a number of experimental studies have examined this effect of reflective reasoning on internal medicine performance, but just on written cases. So not on the fly, not in clinic. They sit down, they give them cases, they make them do the reasoning, and then they see what comes out on the other end. And the summary is that prompted reflective reasoning leads to improved diagnostic accuracy on complex cases. So cases that are hard, cases that you can't use your pattern recognition in. If we make you think about them more and pull out the data that matters, you do better. Also, if we induce availability bias, that decreases diagnostic accuracy, but if we make you think about that case more with this reflective reasoning, it corrects for the bias. There was a recent study earlier this year that actually refuted this point, that these cognitive forcing strategies actually failed to decrease diagnostic error in medical students. This is a much different population than residents and attendings, because medical students, I feel, have a big knowledge gap. You know, if they haven't seen 10 people with adrenal insufficiency, it's really hard for them to pick up on it, no matter if they think harder about the case. They just don't have it in them to come up with the right diagnosis. So what have people done in terms of curriculum and in terms of training people to kind of think this way? So there was one curriculum at Penn. They got 2 papers out of it. It's the same curriculum, really. But the curriculum included, sorry, not chippy or anything. The curriculum included a didactic small group review of cognitive diagnostic errors. So it was just information dump. Then they kind of thought about their cognitive errors or things that they have seen, and they made them reflectively write about them. And then they did some web modules with some videos. And the outcomes were really knowledge. So we trained you to do something. You were able to identify some cognitive biases at the end of the training, but really we didn't assess you in terms of your clinical reasoning on the fly or in a clinical situation. So can they be used in the clinical setting? Can we train people to do this on the fly and not in a simulated environment with written cases or a data dump and a pre-post survey? And we say yes, that it can be used as a teaching tool. So now I'm going to turn it over to Debbie. I have to take my microphone off, though. And she's going to take you through what we've done in terms of this year, in terms of clinical reasoning.
Okay, good. All right. Thank you, Sarah. Hi, everybody. So before getting into the details of our current curricular efforts regarding clinical reasoning within the internal medicine residency training program, I want to give you a little bit of the backstory about how all of this has developed over time. So I want to start by saying that the motivation for this project was not at all any sort of identified deficiency in clinical reasoning at our institution. In fact, I think the general consensus is that everybody here is pretty good. What we do know is that even at an institution like this, where we have an abundance of expert diagnosticians, the education regarding the clinical reasoning process is not standardized. And what can happen here is this can make it hard for learners to intuit the steps that an expert diagnostician takes to know what steps they need to take to reach a diagnosis. And it can, and also, I think as Sarah very nicely highlighted, we know that experts and novices alike are prone to cognitive bias and diagnostic error. And we are therefore interested in any methods available that might help us all to avoid these pitfalls. So keeping these things in mind, when Dr. Follansbee started this process actually many years ago, he did it with sort of one key question in mind. Is it possible to write down in any concise fashion the logical questions that one should ask oneself during the diagnostic process? And so he did this. He started writing down these questions, first based mostly on physiologic and pathophysiologic reasoning, and then incorporating experiences that he's had in the clinical setting, sort of using these questions on a repeated basis systematically on attending rounds in the CCU. And he refined it and changed it over years based on his own experience, and initially really developed it out of clinical experience without consideration of the principles of cognitive psychology, but then began to incorporate some of the relevant principles of cognitive psychology, some of which Sarah mentioned today. And the current version of his two steps back checklist card, and I think actually they're available in the back for anybody who wants them, is number 21. So this has been a process that's sort of taken time to develop over years and years. And so we're going to go through the detailed steps of the checklist a little bit later, but before doing that, what I'd like to do is sort of put all of this in the context of our sort of current curricular efforts. And for the curriculum that we've been working on, we sort of move forward with one hypothesis in mind. And that is that systematic use of a simple list of logical questions in the form of a checklist to consider in the diagnostic process, combined with point-of-care reminders of pertinent cognitive heuristics and biases, could, if used longitudinally over the course of a 3-year residency training program, enable physicians in training to recalibrate their type 1 or intuitive decision-making processes and improve both accuracy and cost efficiency in the diagnostic evaluation. And when I use the word checklist in the context of medicine, this book may come to mind for some of you. In the Checklist Manifesto, Atul Gawande points out the potential value of checklists for use to improve decision-making. He mostly focuses in this book on the effectiveness of checklists in procedural tasks, which are linear and deterministic. It's been well documented that checklists have been used effectively in medical settings to reduce central line infections and in the operating room. But what's less well known is whether these same processes can be used effectively for more complex medical decision-making and for the cognitive processes that we're talking about today. But it's reasonable to wonder whether you could apply these same principles in that setting. And this is something that's sort of become more of a hot topic recently. In 2011, Eli et al. Proposed a general checklist for diagnosis. And in their general checklist for diagnosis, in addition to emphasizing the importance of every provider taking their own personal history and physical exam rather than relying on reports from others, they also proposed taking a diagnostic timeout when evaluating patients. And during that timeout, thinking about flaws in heuristic thinking and potential bias before moving forward with your workup and management. So in that vein, Dr. Follansbee over the years developed his two steps back checklist. And this checklist has evolved to include multiple components that can be pulled out as necessary to target a number of areas in the diagnostic process. 1, diagnostic reasoning, 2, the ordering of tests, and 3, medications. For the purposes of the curriculum that we've been working on recently, we chose to focus first on the diagnostic component of the checklist. And our overarching goal was to introduce it for use in the clinical setting, both for use in patient care and also in clinical teaching, to combat overconfidence bias and to act as a cognitive forcing strategy. And I'd just like to take a minute here to remind you guys that the purpose of a checklist like this is not to teach or inform or to teach people things that they don't already know, but it is to remind oneself of the information that one already knows, but which is easy to overlook or ignore during the process of decision making. So as we moved forward with our curriculum planning process, a committee convened that included master educators, clinical teaching faculty, and researchers. And we worked toward a consensus on a diagnostic checklist that we could use in internal medicine training and incorporate into a clinical reasoning curriculum. And what I'm going to show you now is the checklist that sort of resulted from this committee. The first component is to identify what your initial leading diagnosis is after evaluating the case. And then you're asked to consider what elements of the case support and contradict the diagnosis respectively, and moving on to consider what elements are missing that you would expect to be present if your leading diagnosis were true. And going through this thought process is supposed to help you consider how likely this diagnosis is and whether you should consider alternatives. The next step asks what else could it be, basically asks you for your differential diagnosis and to answer the same 3 questions for each diagnosis that you identify. Question 3 asks the user to explain the findings of the case in terms of pathophysiology. And the point here is to use the pathophysiologic explanation of the case presentation to help you to evaluate the diagnoses that you've already listed to see if they make sense, and also to prompt you potentially to think about other diagnoses that you had not yet considered. And then taking into account all of the information from the first 3 questions, you make a final ranked differential diagnosis. And once we had that settled, we moved forward with our curricular and evaluation efforts in 2 stages. The first stage was a controlled experimental evaluation of the diagnostic checklist that you just saw. And our purpose here was to analyze the effect on diagnostic accuracy using methods much like those used by Mamid's group that Sarah outlined. But maybe even more importantly, to obtain resident feedback regarding the acceptability and potential usability of the checklist in the real clinical setting. And this was with the acknowledgement that perhaps most important to our success moving forward would be the input of the residents, and we wanted to get that early on. Our next stage was implementation and evaluation of a clinical reasoning curriculum that would include our checklist. So let me start by telling you about stage 1. Like I said, this was a controlled experimental evaluation of a diagnostic checklist. Our outgoing 3rd-year residents participated in this evaluation in June of last year. And they basically worked through a set of written clinical cases without and then with our checklist. And we worked in collaboration with Drs. Mamid and Schmidt and used the cases that they had used in several of their investigations. And the outcome that we looked at was diagnostic accuracy, comparing cases diagnosed without the checklist to those with the checklist. This just gives you an idea of what the residents had to do when they were working through these cases. So they would read the case, they would see the checklist prompts as you saw them on the previous slide, and they were asked to answer those A, B, and C questions in this table with the idea that this would allow for direct visual comparison of the elements that supported and did not support each diagnosis and aid in the making of their final differential. As you can see here, a total of 51 PGY3 residents were eligible and invited to participate in this evaluation. 17 were excluded, mostly because other responsibilities precluded their ability to participate. And the remaining 34 residents were randomized to one of 2 sets of cases. You can see here some of the general participant characteristics. The mean age of participants was 30. There were more females than males. And in terms of post-graduation plans, the majority were pursuing general medicine in some form. That includes hospitalist medicine, general medicine fellowships, and people who are practicing primary care. After that was complete, every case that the resident worked through was scored according to the scale that you see here. They were reviewed by 2 independent reviewers, and the second reviewer was blinded to whether the checklist was used. Our CAPA indicates near perfect agreement in our scoring. And let me walk you through this chart, which shows the mean diagnostic accuracy scores without and with the checklist by case. On the x-axis, you'll see the 9 cases that were included in the evaluation, and they are grouped into 2 categories of complexity. The complexity categories were determined based on performance of a separate group of residents on the same cases. The y-axis shows diagnostic accuracy on a scale of 0 to 1. And what I basically want you to note here is that for most cases, the performance with the checklist, which you can see in red, was equal or better to the performance of without the checklist for the most part. You can see here, based on our crude mean diagnostic accuracy scores grouped by case complexity, that the diagnostic accuracy score with checklist use was higher than without for both, but perhaps more significantly for the simple cases than for the complex. And what we did at this point is we did a repeated measures regression analysis where we looked for the effect of checklist use while controlling for complexity. And you can see that in this model, both checklist and complexity were statistically significant in terms of their effect, and that the interaction between checklist and complexity was not statistically significant. As I mentioned in the beginning, one of the really important things that we were looking to get out of this, other than examining the effect of the checklist on diagnostic accuracy, was to obtain feedback from the residents regarding the checklist itself and how they could picture themselves using it in the real clinical setting. And what I'll do now is just go over some of the main themes of the feedback that we got from them. So in general, a number of the residents said, we already think like this, but the checklist helped us to slow down. A number of residents also indicated that they thought the checklist didn't really help them come up with a different diagnosis, but it did increase the confidence that they had in the diagnosis that they had already been considering. They pretty universally said they thought it was most helpful for the complex or more complicated cases and was not helpful for the simple cases, which is interesting to interpret in the context of the results that we just showed, where there may have been more of an effect for simple cases. A number of residents definitely said, I don't need this. I already do this in my own way. And then one really important point that we'll come back to later was that multiple residents pointed out, the checklist didn't help me when I had a knowledge gap. There were some cases where when I used the checklist, it made me want to go and look something up. And of course, in our controlled experimental setting, they weren't able to do that. We also asked the residents to specifically comment about when and where they could see themselves using a process like this in the clinical setting. They were pretty adamant about the fact that they couldn't picture themselves using this all the time or for every case. They did say that for holdovers, ICU transfers, outside hospital transfers, or for any new patient, this process might be helpful. A number of residents felt it would be something that would be useful to pull out or think through if they were feeling stuck about a patient. They thought it would be great for teaching early learners. And interestingly, a number of them brought up that they might want something like this when they felt like they were more alone or independent, such as admitting patients on night float or working in clinic. So conclusions from this study include that use of the 2-steps back checklist led to a statistically significant improvement in resident diagnostic accuracy for written cases. There was a suggestion in our raw data that there may have been more of an effect for simple cases, but this was not statistically significant. And residents generally found the checklist to be acceptable, and they provided valuable insights into potential applications in real clinical scenarios. And you'll see a little bit how things changed as a result of their feedback going into the next stage. One thing that I think is a little bit worth talking about here is some of the differences in our results from the ones that Sarah showed you previously. If you remember, the studies by Mahmoud's group showed pretty consistently improved diagnostic accuracy with the use of reflective reasoning for complex but not simple cases, whereas our study showed an effect overall and perhaps a suggestion of more of an effect for simple versus complex cases. And you might wonder why that is. We have a few hypotheses. One, we had different resident populations and training levels. Their studies were all done internationally with PGY2s. Our study was done in the United States with outgoing PGY3s. You could hypothesize that the more advanced the learner or the more advanced the trainee, the more heuristics and patterns they have to rely on, and therefore the more potentially prone to bias, even for simple cases. In the same vein, residents in general may be more likely to rely on heuristics for simple cases and therefore be more prone to bias and therefore more likely to be helped by something like the checklist. The other thing, which is something that the residents brought up, is that the checklist in this setting couldn't help when a knowledge deficit was the problem, and knowledge deficit is definitely more likely to be a problem for the complex cases. The nice thing is that in the real world setting, if you were using a process like this, you would be able to go and look something up. And finally, perhaps more education or training is required to apply the checklist to complex cases, whereas it might be more straightforward and easy to use for simple cases. So with all that being said, I'd like to move on to stage 2, which was the development, implementation, and evaluation of our clinical reasoning curriculum. The clinical reasoning curriculum was delivered to some of the teaching inpatient medicine teams last fall. And it was delivered in the format of a 4-hour workshop prior to the beginning of the medicine rotation. The workshop included introduction to the principles of clinical reasoning. So you saw a little snippet of what was included in what Sarah presented already today. It also included case-based interactive discussions regarding diagnostic error and cognitive bias. And a large part of the workshop included introduction to an updated version of the 2 Steps Back checklist and discussion regarding ways that this could be used in the clinical setting, both for actual patient care and for clinical teaching. And with that, I'm going to show you the checklist that we introduced as part of the curriculum. We also have cards that have this on it. They're actually the cards that the residents and faculty had who were a part of this curriculum. And you'll notice a few key differences compared to the one that I showed you before. The first main difference is that for this checklist, we divided it into 2 steps, with the idea that the first step could be applied very quickly and easily, even to cases that seem straightforward and where you thought you had a good idea of what the diagnosis was, as sort of a check on your clinical reasoning, whereas the second step could be used for a more in-depth framework when you're not quite sure what's going on. And so the first line of the checklist says, or if you're unsure of the diagnosis, start with step 2. Step 1 starts with the same question that we had for the other checklist, and what fits and what doesn't fit was our briefer way of going through the same 3 questions that we had previously. And you're asked at that point, after considering what fits and what doesn't fit, to state whether you're comfortable with your diagnosis. And if so, it may be appropriate to move on with your confirmatory testing and management, and if not, you move on to step 2. I'll note here that the goal of the curriculum was never for residents to sit down and write things down as they did during our previous evaluation. These are questions more to provoke thought. Step 2 starts by asking the user to go back to the case and to pull out the key elements, including historical elements, elements from the physical exam, and also any available data. And based on those key findings, to create a differential diagnosis, to think about what fits and doesn't fit for each possibility, and then to consider whether there's more information from the history or physical that would either help to refine the diagnosis or to get more information to create new options. Finally, the user is asked again whether they're comfortable with their leading diagnosis. And if they're not, on this checklist there were some suggestions for how to seek information and guidance in the diagnostic reasoning process. So now that we've gone through that, I'll just take 1 minute to ask you to think back to the adrenal insufficiency case, because during the workshop we gave examples of cases and sort of asked the residents to think about how the checklist could have been applied to those cases and whether it might have helped to prevent cognitive bias. So would following the steps of a checklist help to raise red flags that the patient may not have been presenting with yet another viral gastroenteritis? And what would have happened if providers had considered what else could it be during admission 2, for example, maybe instead of admission 4? So with that, I'm going to move on to tell you a little bit more about our curriculum implementation and evaluation. As I mentioned, this happened last fall. The faculty and residents who are rotating on inpatient internal medicine teaching services at Montefiore formed the intervention group, and they participated in the 4-hour workshop. The control group included residents who were on internal medicine at our other training sites, and they basically participated in the usual educational practices during their rotation. In addition to the workshop, residents and faculty who were a part of the intervention group had posters posted in the team rooms that included the items on the checklist, and also received laminated cards that had the checklist on one side and selected cognitive biases on the other. For our evaluation component, we looked at outcomes that were basically in 3 realms. First, acceptability. So faculty and residents who participated in the curriculum filled out surveys at the end. Second, efficacy. And we evaluated this by looking at pre and post resident performance on written clinical cases. And in this case, we looked at both diagnostic accuracy and calibration, or the relationship between confidence and accuracy for these written cases. And finally, we evaluated effectiveness. And for this, we actually performed direct observation of randomly selected Montefiore teams during walk-in teaching rounds, both before and after curriculum implementation. And this was to assess actual use of the curriculum content. This diagram basically shows the flow of participants. You can see that the inpatient teaching teams at Montefiore VA and Shadyside during blocks 3 and 4 all were invited to complete the written cases before the start to their rotation. The Montefiore residents went on to participate in the workshop and were asked to use the checklist during their rotation, while residents at other sites participated in their usual educational practices. All residents were again invited to complete written cases at the end of their rotation. And the other modes of evaluation that I already mentioned, you can see in the top right-hand corner. This just gives you an idea of what the residents were asked to fill out when they worked through written cases during their baseline assessment and after the curriculum. I'll mention here that when we asked residents to fill out the cases, to work through the cases after the curriculum, we did not mandate, ask, or provide them with the checklist to use. So we were really trying to see if there was any difference in the way they approached a case as a result of their month on medicine and the curriculum that they received, without forcing them to write down answers in response to the checklist. So everybody saw a case that looked just like this. So they would read the case. They were asked to provide their differential diagnosis, including up to 5 diagnoses, and also to estimate the likelihood that each diagnosis on their differential was the actual diagnosis, and finally to rate their confidence on a scale of 0 to 10 that their number 1 diagnosis was correct. And the main data that I have to go over with you today is our preliminary qualitative acceptability data. So 83% of attendings who participated in the curriculum filled out the survey. 95% of those indicated that they were somewhat or very likely to use the content going forward. They felt pretty universally that the checklist was most useful for complex cases, not so useful for simple or straightforward cases. A number of attendings independently brought up that they thought the naming of the cognitive biases was a useful teaching tool for their team, and a couple actually thought that it may have been helpful to have a poster with the cognitive biases in their room in addition to a poster with the checklist. Some reported that they thought they were already using these skills in their own way and that it was difficult to sort of change their teaching style to incorporate a new framework. About 80% of residents who participated in the curriculum filled out the survey. 77% indicated that they were somewhat or very likely to continue to use the content going forward. They agreed with the attendings that it was most useful for complex cases. They also pretty universally reported that they thought it was best used on attending teaching rounds and that they had a hard time incorporating it into their bedside walk rounds and to bedside patient discussions. And interns specifically identified a number of barriers to using the checklist in the clinical setting. And those barriers included insufficient time and feeling overwhelmed by other tasks that they had. Keep in mind that these are interns in month 3 and 4 of internship, and this may have been their first floor month. So analysis of our remaining efficacy and effectiveness data is ongoing, so I'm going to have to ask you to stay tuned for that. And at this point, I'll conclude by talking about some of our future directions, and we would also love to get input from you guys about ways that you could see this sort of curriculum being useful. One of the biggest things we've learned through this whole process is that if curricular efforts like this are to be successful, it will probably be necessary to incorporate components of this type of curriculum into multiple educational venues throughout the residency training longitudinally, and that a one-time workshop of any kind is probably unlikely to create a sustained effect. We've also thought a lot about the fact that in order to get sort of a culture change in terms of considering diagnostic error, cognitive bias, and talking about it, there have to be interventions at all levels from medical students on up through attending so that everybody's on the same page. Things that we have planned for the immediate future are to post some of the cognitive bias posters in the team rooms in response to the requests that we had on our surveys. We have already incorporated teaching some of these principles into Chiefs cases, both at Montefiore and up at the VA, as a way to bring up topics of diagnostic error and cognitive bias and to role model using some of this framework in approaching cases. Morning Report seems like another logical venue to use this sort of framework in approaching cases. And like I said, we'd love to have your suggestions on how you guys could see this fitting in. So with that, I'm going to acknowledge the large group of people that have contributed to this project over the last couple of years. And we'll stop here for any comments or questions.